Assalamu alaikum colleagues. Welcome to our new lecture. In today's lecture, I will discuss a silent threat, that is congenital hypothyroidism and maternal thyroid disease. Starting with a condition that is a silent thief of potential. The classic textbook baby with congenital hypothyroidism is described as having a coarse facies, a large tongue, and a distended abdomen with an umbilical hernia. That is, if a baby is with congenital hypothyroidism, we usually have to see following features so that we can confirm it clinically. That is, coarse facial features, umbilical hernia, large protruded tongue, distended abdomen. But if you wait to see those signs, you have might miss the boat. The vast majority of babies with congenital hypothyroidism look perfectly normal. Parents often describe them as good babies. They sleep a lot, don't cry much, and they feed slowly. But while they are sleeping, their brain is starving. Without thyroxine, myelination halts and their IQ is dropping by the day. So, in this lecture, we will master the 2025 screening protocol. Here, we are focusing on 2025 screening protocol for hypothyroidism. So, what we deal in this lecture is all about the screening protocol, the precise dosing of levothyroxine to protect the brain. So, dosing and the high stakes management of the jittery infant born to a mother with Graves disease. So, we are not only dealing with congenital hypothyroidism here, but also the maternal thyroid disease, which can lead to a baby which is jittery. So, dosing of levothyroxine and the maternal condition as well. So, here, starting with the congenital hypothyroidism, that is one of the most common preventable cause of severe learning disability. Because clinical signs are absent, we rely entirely on the newborn blood spot screening. So, we usually screen all the neonate and usually at day 5. Why at day 5? Because immediately after birth, the stress of cold exposure triggers a massive physiological TSH surge. If you screen at day 1 or 2, you will get a false positive. So, we wait for this to settle. Why? Because of physiological surge at day 1 and day 2. So, usually we screen all the neonate at day 5. Nelson textbook of pediatrics remind us that 85% of cases are due to dysgenesis. So, hypothyroidism is usually due to Dysgenesis. Dysgenesis is usually 85%, and the second, which is 15%, is dysharmogenesis, is only 50%. So 85% are due to dysgenesis, that is agenesis, hypoplasia, or ectopic gland, and only 10 to 15% is due to dysharmogenesis, that is enzyme defects. So majority of the child with congenital hypothyroidism is due to anatomical defect. So here is 85% of the neonate which are congenital hypothyroid is due to dysgenesis of the gland. So when we screen at day 5, we must remember the values so that we have a clear cut definition or clear cut values in our mind so that we can label any neonate, that is they are either hypothyroid or not. So according to Neonatal Guideline 2025, till 28, it categorizes neonate into three different zones. Zone 1 having the value of less than 8 mu per liter is called as negative. So all those babies in which the screening test result at day 5 is less than 8 are usually negative. Zone 2, that is the borderline, is in between 8 to 20. So this is the borderline. We do not treat this zone, but we can't ignore it as well. We have to repeat the blood spot screening in 7 to 10 days. So if your report is in between 8 to 20, we have to repeat the screening in 7 to 10 days. And if the repeat is still greater than 8, then we have to refer this neonate to the pediatrician or the endocrinologist. So, zone 1 is the negative zone or the safe zone, which we can conclude that this child is not having the hypothyroidism. Zone 2 is the borderline, in which the values are in between 8 to 20. We have to repeat the screening, and if the result is again greater than 8, we should send this child for the consultation of endocrinologist. And the third one is zone 3, in which the values are greater than 20. They are called as positive screen. So these babies need venous confirmation. So we urgently send for venous confirmation for free T4 and TSH. And one thing which is more important here, we do not wait for the venous result to start treatment. So do not wait for the treatment, start immediately if there is high suspicion and or the TSH is markedly elevated. So if the TSH is greater than 40 or there is high clinical suspicion, we should not wait for venous confirmation. We should start treatment immediately. So we have divided the screening result into three. First one is the safe zone, which is the negative one, and value is less than 8. Zone 2 is in between 8 to 20, which is borderline, in which we have to repeat the screening in 7 to 10 days, and if the result is again greater than 8, we have to refer this neonate immediately to the pediatrician or the endocrinologist to decide whether to start treatment or not. And the zone 3 is positive, that is greater than 20. So we send this child immediately to for venous confirmation for free T4 and TSH values. But if the TSH in newborn screening test is greater than 40, or we have a high clinical suspicion that this child is having hypothyroidism, we should not wait for the venous confirmation result to arrive. We should start treatment immediately. But this is for the neonate. We have a different scenario for preterm babies. So for preterm babies, that is babies less than 32 weeks, there is some different scenarios, because these premature infants have an immature hypothalamic pituitary thyroid axis, that is they have still developing their hypothalamic pituitary and thyroid axis. So they may not mount a TSH response immediately, or they may have hypothyroxemia of prematurity. So in this preterm neonates, we do not rely a single screen at day 5. So single screen at day 5 in this neonate is insufficient. We usually screen again at 28 days of life. So we require two screening results in preterm infants. First one is at day 5 and the second one at 28 days of life or at discharge, whichever is sooner. So if the baby is admitted in your NICU and you are discharging that baby at 24 days, so you can repeat that screening test at day 24. But if he or she is not admitted at your NICU, so repeat at 28 days of life. So in preterm, we have two screening test results so that we can decide either they have hypothyroidism or not. This is because we have to catch the delayed rise. In these babies, TSH usually rises after day 5 due because of immature hypothalamic pituitary thyroid axis. So if you just rely on day 5 result, we might miss some of the neonate having hypothyroidism. After this, you have a clear cut mind that this child is either hypothyroid or not. And you have confirmed this with venous result, that is high TSH and low free T4. So we do not wait for any delay because time is brain. We need to normalize the T4 rapidly to ensure neuronal migration. So start treating these childs immediately because we have to ensure neuronal migration so that we have a normal brain development. So, in management, we have only a single drug for the treatment, which is levothyroxine, that is T4. Neonatal guideline and Gomila recommend an aggressive starting dose, that is 10 to 15 micrograms per kg per day. We do not aim for the average. We aim to keep the free T4 in the upper half of the normal reference range to ensure adequate cerebral delivery. One more thing, this is for the dosing, but how to use this dose? We use crushed tablets. Crush the tablets with a small amount of breast milk or water. Some locality have liquid suspension, but liquid thyroxine is unstable and can lead to erratic absorption. So stick to the tablet. So avoid liquid suspension. Stick with the crushed tablets. You have diagnosed the case and you have started the treatment. But you have to counsel the mother for dose compliance, because if the dose is being missed, the child can lead to brain injury or delayed brain growth. So you have to counsel parent that this is not your fault. You can have a normal IQ baby with daily treatment. So you have to dose your child daily. But if you miss doses, the brain does not recover. So compliance is non-negotiable. Do not miss any dose. Now, this is the one side of the scenario. The next scenario is the maternal grave disease. So, in this scenario, the child is irritable. The baby which is delivered would be irritable. This is due to grave disease, either present or past. Why it is so? Grave disease is a condition in which there are antibodies which can cross the placenta and stimulate the fetal thyroid, just like they stimulated the mothers. So in maternal grave disease, mother have antibodies. These antibodies can cross placenta easily, so they can stimulate the fetal thyroid as well. If they stimulate the fetal thyroid, it can lead to an irritable child. But here is a clinical trap. Be careful. If the mother was treated with antithyroid drugs like carbimazole during pregnancy, these drugs also cross the placenta, resulting in euthyroid neonate. This is because the carbimazole, which is taken by mother, is being crossed the placenta and resulting in the suppression of baby's thyroid gland. So, what is the clinical trap here? If mother is on anti-thyroid drugs, these drugs can cross and reach to fetal thyroid, suppresses it, and resulting in a euthyroid baby. But after 7 to 10 days, when the baby system washes out the drug, but the antibodies last for months, the baby suddenly becomes thyrotoxic at home. So, at 7 to 10 days, drug is washed out, that is carbamazole, but antibodies remain, resulting in a condition which we called as thyrotoxic. So baby become thyrotoxic when the drug wash out. So those babies, neonates, which have neonatal thyrotoxicosis have the impression looks like drug withdrawal. What should be the findings or clinical signs you should look for? So babies neonatal thyrotoxicosis, babies look like irritable, having jittery movements, having poor sleep, tachycardic, usually heart rate greater than 180, high feed demand but with weight loss. You should also look for craniosynostosis, that is premature fusion of the sutures or frontal bossing. So specific signs you should look for: craniosynostosis or frontal bossing. How you manage this baby or mother? The child which is born with mother having grave disease, having a management protocol, all women with a history of graves, even if they had a thyroidectomy years ago, must have thyroid receptor antibodies titers checked in pregnancy. So titers should be checked in pregnancy. And for the babies, we should not test the cord blood, should not screen using cord blood. This might be misleading. We should test these babies at 48 hours for serum, TSH, and free T4. If the mother had high antibodies, the baby needs clinical review and repeat labs at day 10 to 14 to catch the delayed onset. So, we usually again send samples at day 10 to 14 to catch any delayed onset. If the baby is symptomatic, we use carbimazole to block the production and propranolol to protect the heart. So, if the baby is symptomatic, we use carbimazole and propranolol. For the board exams and for the emergency room, watch out the triad of the missed congenital hypothyroidism. They usually present at 3 week with prolonged jaundice, usually unconjugated, constipation, and umbilical hernia. So, if a baby is being missed and it is landed to your emergency department with a triad of prolonged jaundice, constipation, and umbilical hernia, screen for congenital hypothyroidism. What is the most critical investigation for these babies? This is thyroid function test. While umbilical hernias are common, this specific triad, that is prolonged unconjugated jaundice, umbilical hernia, and constipation, is a hallmark of hypothyroidism. Do not assume the newborn skin was normal. Errors can happen. Check it again. So, we have dealt with congenital hypothyroidism and those babies which are delivered by mother having grave disease. So, to summarize this lecture, we should having strict timing for this management, and we should screen all babies at day 5 and day 28 for the preterms as well. We should aggressively treat those having congenital hypothyroidism to avoid any brain abnormality or delayed brain development. Watch for babies which are irritable, jittery, poor sleep, tachycardic for graves, and should be watched for day 10 crash. Inshallah, in the next video, we will discuss the adrenal gland, specifically the life threatening salt wasting crisis, that is congenital adrenal hyperplasia. So, for the next video, we will discuss congenital adrenal hyperplasia. This lecture is basically prepared after having different books on board. For example, Neonatal Guidelines 2025 till 28, Nelson Textbook of Pediatrics Chapter 601, Gomila's Neonatology 8th edition Chapter 84. This lecture is purely for educational purpose and specifically for professionals and medical grads or nursing students. This is not intended for any consultation. If you watch this video, please consult your doctor before any medical treatment. Till next video, Allah Hafiz.